Good morning, everyone. This is Kechi Joma from The Ohio State University, Columbus, Ohio. I have here with me Dr. Michelle Albert, who's the Chief of Cardiovascular Medicine at Howard University. Dr. Albert, how long have you been coming to the ACC?
I've been coming to the ACC for at least 15 years. I started coming when I was a fellow. I actually was an FIT. I was on several of the FIT committees. And I have thoroughly enjoyed this program this weekend. I've had the opportunity to be involved in several programs. As a matter of fact, the Association of Black Cardiology program that is juxtaposition to the ACC program, as well as the ACC itself. I went to the distinguished young investigator talk today given by Dr. Jessica Mega, which was outstanding, about genetics and antiplatelet agents. So I think as an FIT has a lot to learn at this conference. My biggest piece of advice would be try to touch base with the leaders in cardiovascular medicine. Most often they're willing to actually sit over coffee and have a chat with you about whatever topic you might want to ask them. I think the key is to actually connect with them before you actually come to the conference by email and say, I'm going to be at the conference, and can you spend 5 minutes, 10 minutes, 15 minutes of your time chatting with me about my career.
You presented today a poster and data about the BVS stents. Could you tell us more about this?
Yes, it was the poster about Absorb Extend, which is a trial after Absorb cohort A and B with the BVS of Abbott. And now we have the clinical result at 2 years follow-up, about 450 patients. And it's the first so important trial with BVS. And it's very interesting to appreciate the clinical results, which are very, very good concerning the percentage of MACE, which is less than 7% at 2 years follow-up. And also the stent thrombosis rate, which is about 0.9% at 2 years. And with this result, we can talk that we have the same result than with Xience V stent in the different SPIRIT trials. And it's very, very, very interesting for the future. But it is important to precise that the results are with very simple lesions. We have lesions only type A or B1, more than 60%. And the number of complex lesions is very low, about 30-35%. But in this type of specific lesions which are simple, we have excellent results at 2-year follow-up.
And then if I could just ask the both of you, did you find any other studies here that were of particular interest, or sessions here at ACC 2014 that were particularly important for you as interventional cardiologists in the field?
I also look at the result of the TAVR and the comparison between the core valve and surgery. And it's interesting to note that the result in normal populations are better with TAVR, with core valve, than with classical surgery, concerning the mortality rate at 1 year follow-up. And I think that it's very, very relevant for the future with this new technology. And I don't know if Dr. Lemusier has other clinical results.
Second trial is the Simplicity trial, of course, and negative results. But in my opinion, maybe this is not the end of the technique, and that's the news we had from ACC, and maybe we are waiting for more results about renal denervation.
What are your thoughts on the highlights of the ACC this year, and what do you think was excited this year?
Well, we haven't really had a great heart failure trial, but I chaired a session yesterday that had some really interesting papers about maybe looking at the heart failure patients a little bit differently. One of the fellows that presented, he was actually a fellow from the UK in John Cleland's lab, looked at the patients who came in very short of breath, and the patients who came in not so short of breath but had more edema and their pressures were higher, and yet the short of breath patient requires this immediate, we got to run, we got to make them better. Well, the patients with the more chronic onset were the patients who had the highest mortality and the highest rate of hospitalizations. So maybe we haven't been getting the right population into trials, and that may help us, finesse it a little bit. The other thing that's fascinating, the February 2014 issue of JACC Heart Failure, which I'm on the editorial group, has a paper called bendopnea. What is bendopnea? Our patients lean forward to tie their shoelaces and they get more short of breath. We've known about this for a long time. It's a very classical symptom, particularly in the men who wear shoes with shoelaces. And when they tell me that they can't bend over, I know that they're pretty sick and pretty volume overloaded. But Mark Drasner's group out of Texas actually looked at pressures in these patients. And they're patients who already have high central pressures, and obviously when they bend over, the central pressures go up. And there's a wonderful editorial by Lynn Stevenson's group, and so I counsel everybody to go read it because it's kind of fun reading. So we have a new term, bendopnea.
Very nice. Thank you very much for your time. It was very nice seeing you here at the ACC, and I hope you have a safe trip back home.
Good to see you. I'm happy to see more and more fellows here.